Over 65. These 8 medications could trigger a heart attack. Medication number 3 increases heart attack risk by 300% within the first 30 days of use. Heart attacks kill more seniors than any other single cause of death, claiming over 350,000 American lives annually. While most people focus on diet, exercise, and cholesterol levels as heart attack risks, a hidden danger lurks in medicine cabinets across the country: prescription medications that dramatically increase cardiovascular event risk in adults over 65 years old. The paradox is devastating. Seniors take medications to improve health and prevent disease, yet certain drugs prescribed routinely to elderly patients actually trigger the very cardiovascular events they're meant to prevent or have nothing to do with preventing. Understanding how medications trigger heart attacks requires grasping several cardiovascular mechanisms. Some drugs increase blood pressure acutely, creating hypertensive crises that rupture vulnerable atherosclerotic plaques in coronary arteries. Others cause sodium and fluid retention, overloading the cardiovascular system and precipitating acute heart failure that reduces coronary perfusion. Some medications increase heart rate and contractility dramatically, raising myocardial oxygen demand beyond what diseased coronary arteries can supply. Others promote blood clot formation through various mechanisms, including platelet activation, increased coagulation factor production, or endothelial dysfunction. Additionally, certain drugs cause coronary artery spasm, suddenly constricting arteries and blocking blood flow even in the absence of significant atherosclerosis. Some medications alter electrolyte balance, particularly potassium and magnesium, creating conditions for fatal arrhythmias. Others interact with existing cardiac medications, reducing their effectiveness or creating toxic combinations. The vulnerability of seniors to medication-induced heart attacks stems from age-related physiological changes. Aging kidneys metabolize and excrete drugs more slowly, causing accumulation to toxic levels at standard doses. Aging livers process medications less efficiently, prolonging drug half-lives and intensifying effects. Reduced cardiac reserve means elderly hearts cannot compensate for additional stresses imposed by medications. Pre-existing coronary artery disease makes seniors particularly vulnerable to any factor reducing oxygen supply or increasing oxygen demand. Additionally, polypharmacy, taking multiple medications simultaneously, creates unpredictable drug interactions that can trigger cardiovascular events. The average senior over 65 takes 4 to 6 prescription medications daily, with 25% taking 10 or more. Each additional drug increases interaction risk exponentially, not linearly. Research published in JAMA Cardiology and Circulation documented that medication-induced cardiovascular events account for 15 to 25% of heart attacks in seniors over 70 years old. Many of these events are preventable through careful medication selection, appropriate dosing, monitoring for side effects, and regular medication reviews to eliminate unnecessary drugs. The tragedy is that prescribers often don't consider cardiovascular risks when adding new medications to elderly patients' regimens. A rheumatologist prescribes anti-inflammatory drugs for arthritis without checking cardiac history. A psychiatrist starts antidepressants without assessing cardiovascular contraindications. A urologist prescribes decongestants for prostate symptoms without reviewing blood pressure. Each specialist focuses on their organ system, missing the big picture of total medication burden and cumulative cardiovascular risk. Primary care physicians, who should coordinate care and review total medication lists, often lack time during brief appointments to conduct thorough medication reconciliation. The 8 medications discussed in this video represent those with the strongest evidence for triggering heart attacks in seniors over 65. Each medication class is explained with mechanisms of cardiovascular harm, statistics on heart attack risk increase, populations at highest risk, and safer alternatives when available. These recommendations come from major cardiology organizations, including the American Heart Association, American College of Cardiology, European Society of Cardiology, and Beers criteria for potentially inappropriate medications in older adults published by the American Geriatric Society. Understanding these risks empowers seniors and their families to have informed discussions with physicians about whether benefits of these medications outweigh cardiovascular risks in their individual situations. Sometimes medications on this list are necessary and life-saving despite risks, but often, safer alternatives exist or the medication isn't truly necessary, making discontinuation the best choice. Click subscribe right now. Leave a like for the algorithm. Share with anyone over 65 taking multiple medications. Comment which medication on this list surprises you most. Now let's examine 8 medications that could trigger heart attacks in seniors over 65, starting with number 8 and building to the most dangerous, the one increasing heart attack risk by 300% within the first 30 days of use. Medication number 8, decongestants, pseudoephedrine, phenylephrine, causing acute hypertensive crises. Over-the-counter decongestants containing pseudoephedrine or phenylephrine are among the most dangerous medications for seniors with cardiovascular disease, yet they're available without prescription and widely used for sinus congestion, allergies, and cold symptoms. These medications work as sympathomimetics. They mimic adrenaline and noradrenaline, stimulating alpha-adrenergic receptors throughout the body. This causes vasoconstriction, blood vessel narrowing, that reduces nasal swelling and congestion, providing symptomatic relief. But systemic vasoconstriction from oral decongestants doesn't limit itself to nasal blood vessels. These drugs constrict blood vessels throughout the entire cardiovascular system, causing acute blood pressure increases of 20 to 30 mmHg systolic and 10 to 15 mmHg diastolic within hours of ingestion. For seniors with pre-existing hypertension or coronary artery disease, this acute pressure surge can rupture vulnerable atherosclerotic plaques in coronary arteries. Plaque rupture exposes thrombogenic material to the bloodstream, triggering rapid clot formation that completely occludes the artery, causing myocardial infarction, heart attack. Additionally, the increased blood pressure dramatically increases afterload, the resistance the heart must overcome to pump blood. This raises myocardial oxygen demand precisely when coronary blood flow may already be compromised by atherosclerosis, creating supply-demand mismatch that triggers ischemia and infarction. Research published in American Journal of Medicine found that pseudoephedrine use increased blood pressure by an average of 25/15 of a millimeter of mercury in hypertensive patients, with some individuals experiencing increases exceeding 40 millimeters of mercury systolic. These acute hypertensive crises can precipitate stroke, heart attack, or acute heart failure. Case reports document numerous myocardial infarctions in elderly patients within hours of taking standard over-the-counter doses of decongestants. Many patients didn't realize these harmless cold medicines posed cardiovascular risks because no prescription was required. The FDA requires warning labels on decongestant packaging stating, "Do not use if you have heart disease or high blood pressure," but many seniors don't read fine print or don't consider their controlled hypertension as contraindication if they take blood pressure medications. Populations at highest risk include anyone with hypertension, even if controlled on medications, coronary artery disease or prior heart attack, heart failure, arrhythmias, cerebrovascular disease or prior stroke, and those taking MAO inhibitor antidepressants, which interact dangerously with decongestants. What you must do is avoid all oral decongestants containing pseudoephedrine or phenylephrine if you have any cardiovascular disease. Read labels carefully. These ingredients hide in multi-symptom cold and sinus products under brand names like Sudafed, Sudafed PE, Mucinex D, and countless combination products. Safer alternatives for nasal congestion include saline nasal sprays or rinses providing mechanical congestion relief without systemic effects, nasal corticosteroid sprays like fluticasone reducing inflammation without cardiovascular effects, and treating underlying allergies with non-sedating antihistamines like loratadine or cetirizine. If congestion is severe and refractory, discuss with your physician whether short-term use of nasal decongestant sprays, oxymetazoline, phenylephrine nasal spray, might be appropriate. These have minimal systemic absorption compared to oral decongestants, but can cause rebound congestion if used longer than 3 days. Medication number 7, nonsteroidal anti-inflammatory drugs, NSAIDs, increasing heart attack and stroke risk significantly. NSAIDs, including ibuprofen, naproxen, diclofenac, meloxicam, celecoxib, and ketorolac, are among the most commonly used medications worldwide, available both over-the-counter and by prescription for pain and inflammation relief. For seniors over 65, NSAIDs dramatically increase cardiovascular event risk through multiple mechanisms. These drugs inhibit cyclooxygenase, MOT-SAKOX enzymes that produce prostaglandins involved in inflammation, pain, and fever. But prostaglandins also regulate critical cardiovascular functions. COX-2 inhibition reduces prostacyclin production by vascular endothelium. Prostacyclin normally prevents platelet aggregation and causes vasodilation, protecting against clot formation and maintaining blood flow. Reducing prostacyclin shifts the balance toward prothrombotic and vasoconstrictive states, increasing heart attack and stroke risk. Additionally, NSAIDs cause sodium and fluid retention by affecting kidney prostaglandin synthesis. This increases blood volume and blood pressure, worsening heart failure and hypertension, both major heart attack risk factors. NSAIDs also cause direct endothelial dysfunction, impairing the ability of blood vessel lining to regulate blood flow and prevent clot formation. This accelerates atherosclerosis progression and destabilizes existing plaques. Research published in European Heart Journal examined over 10 million NSAID users and found that any NSAID use, even for short durations, increased heart attack risk by 20 to 50%, depending on the specific drug and dose. Higher doses and longer durations increased risk further. Diclofenac showed the highest cardiovascular risk, increasing heart attack risk by 50% and cardiovascular death risk by 70% compared to non-users. Ibuprofen at high doses, 400 milligrams daily or more, increased risk by 48%. Even naproxen, often considered the safest NSAID, increased risk by 20 to 30%. The risk begins within the first week of use and remains elevated throughout treatment. Contrary to previous beliefs, there's no safe duration of NSAID use. Cardiovascular risk exists from the first dose. Populations at highest risk include those with prior heart attack or stroke, heart failure, hypertension, diabetes, chronic kidney disease, and those taking aspirin for cardiovascular protection. NSAIDs interfere with aspirin's antiplatelet effects. What you must do is avoid NSAIDs if you have cardiovascular disease. Use acetaminophen, Tylenol, as first-line pain reliever instead. While acetaminophen doesn't reduce inflammation like NSAIDs, it provides effective pain relief for most conditions without cardiovascular risks at recommended doses under 3,000 mg daily. For inflammatory conditions like arthritis requiring anti-inflammatory treatment, discuss alternatives with your physician, including low-dose prednisone, though this has other risks, topical NSAIDs like diclofenac gel, providing localized relief with minimal systemic absorption, or disease-modifying medications for specific conditions. If NSAIDs are deemed necessary despite cardiovascular risks, use the lowest effective dose for the shortest duration possible. Naproxen appears to have the lowest cardiovascular risk among oral NSAIDs, though risk still exists. Never combine NSAIDs with aspirin for cardiovascular protection. NSAIDs block aspirin's antiplatelet effects, negating its protective benefits while adding cardiovascular harm. Medication number 6, testosterone replacement therapy accelerating atherosclerosis and increasing clot formation. Testosterone replacement therapy has exploded in popularity over the past 2 decades, with millions of men over 65 using testosterone gels, patches, injections, or pellets to treat low T symptoms, including fatigue, decreased libido, and reduced muscle mass. While testosterone deficiency is real and treatment can benefit appropriately selected patients, Indiscriminate testosterone use in elderly men significantly increases cardiovascular event risk through multiple mechanisms. Testosterone increases hematocrit, red blood cell concentration, by stimulating erythropoietin production and directly affecting bone marrow. Higher hematocrit increases blood viscosity, making blood thicker and more prone to clotting. Hematocrit levels above 52 to 54% substantially increase thrombotic event risk. Testosterone also adversely affects lipid profiles, reducing HDL good cholesterol by 10 to 15% while having variable effects on LDL bad cholesterol. Lower HDL impairs reverse cholesterol transport from arteries back to the liver, accelerating atherosclerosis. Additionally, testosterone increases platelet aggregation, the tendency of platelets to stick together forming clots. Combined with increased hematocrit and adverse lipid changes, this creates a prothrombotic state ideal for heart attack and stroke. Research on cardiovascular safety of testosterone has shown conflicting results, with some studies showing increased risk and others showing neutral or even protective effects. This confusion stems from different patient populations, dosing regimens, and outcome definitions across studies. However, the most rigorous evidence suggests significant cardiovascular risk. A 2014 study published in JAMA found that men over 65 with pre-existing cardiovascular disease who started testosterone therapy had double the rate of heart attacks, strokes, and death compared to similar men not receiving testosterone. The FDA added warnings to all testosterone products in 2015, stating that testosterone may increase risk of heart attacks and strokes and should only be used for conditions associated with structural or genetic causes of testosterone deficiency, not age-related decline alone. The testosterone trials published in JAMA in 2017 found that testosterone increased coronary artery plaque volume measured by CT angiography compared to placebo, suggesting accelerated atherosclerosis development during treatment. Populations at highest risk include men over 65 with prior heart attack or stroke, heart failure, uncontrolled hypertension, hematocrit above 50% at baseline, and multiple cardiovascular risk factors. What you must do before starting testosterone is undergo comprehensive cardiovascular risk assessment, including lipid panel, blood pressure measurement, hematocrit testing, and possibly coronary calcium scoring or stress testing if significant risk factors exist. If testosterone is prescribed, regular monitoring every 3 to 6 months should include hematocrit. Discontinue if exceeds 52 to 54%, lipid panel, blood pressure, and cardiovascular symptom assessment. Consider whether symptoms attributed to low T might have other causes, including depression, sleep apnea, obesity, or medication side effects. Treating underlying causes may improve symptoms without testosterone's cardiovascular risks. If testosterone is necessary, use the lowest dose achieving symptom improvement. Higher doses don't provide additional benefits, but increase adverse effects, including cardiovascular events. Medication number 5. Systemic corticosteroids causing fluid retention, hypertension, and metabolic dysfunction. Systemic corticosteroids, including prednisone, methylprednisolone, dexamethasone, and hydrocortisone, are powerful anti-inflammatory and immunosuppressive medications prescribed for conditions including COPD exacerbations, asthma, rheumatoid arthritis, polymyalgia rheumatica, inflammatory bowel disease, and autoimmune conditions. While these medications are life-saving for many conditions, they significantly increase cardiovascular event risk through multiple mechanisms, particularly in elderly patients requiring chronic therapy or frequent short courses. Corticosteroids cause sodium and fluid retention by activating mineralocorticoid receptors in the kidney. This increases blood volume and blood pressure, with systolic pressure increases averaging 10 to 15 mmHg, but sometimes exceeding 30 mmHg in susceptible individuals. Additionally, corticosteroids worsen glucose metabolism and insulin resistance, raising blood sugar levels and precipitating or worsening diabetes. Hyperglycemia accelerates atherosclerosis and increases cardiovascular risk substantially. Corticosteroids increase LDL cholesterol and triglycerides while decreasing HDL cholesterol, creating a highly atherogenic lipid profile. Combined with hypertension and glucose intolerance, this creates optimal conditions for atherosclerotic plaque development and rupture. Corticosteroids also increase platelet activation and coagulation factor production, creating prothrombotic conditions. Some studies suggest increased fibrinogen levels and enhanced platelet aggregation during corticosteroid therapy. Research published in Annals of Internal Medicine found that current corticosteroid users had 30 to 40% increased cardiovascular event risk compared to non-users. Risk was dose-dependent, with higher doses causing greater increases. Even short courses of corticosteroids increased risk. Patients receiving prednisone bursts for COPD or asthma exacerbations had increased heart attack rates in the 30 days following treatment compared to baseline periods. The cardiovascular risk persisted for months after corticosteroid discontinuation, suggesting lasting effects on vascular function and metabolism beyond the treatment period. Populations at highest risk include those with pre-existing hypertension, diabetes, heart failure, coronary artery disease, and those requiring high doses or long-term therapy. What you must do, if prescribed corticosteroids, is use the lowest effective dose for the shortest duration possible. For chronic conditions, work with physicians to develop steroid-sparing strategies using other immunosuppressive medications, allowing corticosteroid dose reduction. Monitor blood pressure, blood sugar, and weight closely during corticosteroid therapy. Report increases to your physician promptly. Adjustments to blood pressure or diabetes medications may be necessary. Maintain strict dietary sodium restriction during corticosteroid therapy to minimize fluid retention. Limit sodium intake to under 2,000 mg daily, avoiding processed foods, restaurant meals, and adding salt to food. If taking corticosteroids chronically for conditions like polymyalgia rheumatica or rheumatoid arthritis, optimize cardiovascular risk factor control, including blood pressure management, statin therapy if indicated, glucose control, and regular exercise to counteract some metabolic effects. Never abruptly stop corticosteroids after long-term use. This can cause adrenal crisis. Taper gradually under physician supervision. Medication number 4. Antipsychotic medications causing sudden cardiac death from arrhythmias. Antipsychotic medications including haloperidol, risperidone, olanzapine, quetiapine, and aripiprazole are prescribed not only for schizophrenia and bipolar disorder, but increasingly for behavioral symptoms in elderly dementia patients, despite FDA black box warnings against this use. For seniors over 65, antipsychotics dramatically increase cardiovascular death risk through multiple mechanisms. These drugs prolong the QT interval on electrocardiogram, the time required for heart ventricles to depolarize and repolarize during each heartbeat. Prolonged QT interval predisposes to torsades de pointe, a potentially fatal ventricular arrhythmia where the heart's electrical activity becomes chaotic, preventing effective pumping. Torsades can degenerate into ventricular fibrillation and sudden cardiac death within seconds. Different antipsychotics prolong QT to varying degrees. Haloperidol, thyroidazine, and ziprasidone cause the most pronounced QT prolongation. But all antipsychotics carry some arrhythmia risk, particularly when combined with other QT prolonging drugs or in patients with baseline QT prolongation. Additionally, antipsychotics cause orthostatic hypotension, blood pressure dropping when standing, through alpha-adrenergic receptor blockade. This can trigger reflex tachycardia and myocardial ischemia in patients with coronary artery disease. Antipsychotics also cause metabolic syndrome with weight gain, insulin resistance, diabetes, and dyslipidemia, all increasing long-term cardiovascular risk. Olanzapine and clozapine cause the most severe metabolic effects. Research published in JAMA documented that elderly dementia patients prescribed antipsychotics had 60 to 70% increased mortality compared to similar patients not receiving antipsychotics. Much of this excess mortality was cardiovascular, including sudden cardiac death, heart attack, and stroke. The FDA issued black box warnings on all antipsychotics in 2005, stating that elderly dementia patients treated with antipsychotics are at increased risk of death, and these drugs are not approved for dementia-related psychosis. Despite these warnings, antipsychotic prescribing to elderly dementia patients remains common because behavioral symptoms like agitation and aggression are difficult to manage, and non-pharmacological approaches require more time and resources than many facilities can provide. Populations at highest risk include elderly dementia patients, those with baseline QT prolongation or cardiac arrhythmias, heart failure patients, and those taking other QT prolonging drugs, including certain antibiotics, antiarrhythmics, and antidepressants. What you must do is avoid antipsychotics for behavioral symptoms in dementia whenever possible. Non-pharmacological approaches should be first line, including identifying and treating underlying causes of agitation, pain, constipation, urinary retention, infection, environmental modifications reducing overstimulation, structured routines and familiar activities, and music therapy or other calming interventions. If antipsychotics are absolutely necessary for safety, use the lowest effective dose for the shortest duration possible. Reassess need weekly, attempting dose reduction or discontinuation as soon as symptoms improve. Obtain baseline electrocardiogram before starting antipsychotics, checking QT interval. If QTc, corrected QT, exceeds 500 milliseconds, antipsychotics are contraindicated due to prohibitive arrhythmia risk. Choose antipsychotics with lower QT prolongation risk, like quetiapine or aripiprazole, over higher-risk options, like haloperidol or ziprasidone. Avoid combining multiple QT prolonging drugs. Review all medications for QT effects when antipsychotics are prescribed. Medication number 3, COX-2, selective NSAIDs, celecoxib, rofecoxib, increasing heart attack risk by 300%, most dangerous in first 30 days. COX-2 selective NSAIDs, also called coxibs, were developed to provide anti-inflammatory pain relief with less gastrointestinal toxicity than traditional NSAIDs. The theory was that selectively inhibiting COX-2, inflammation, while sparing COX-1, stomach protection, would reduce ulcer risk. This worked. Coxibs cause fewer stomach ulcers than traditional NSAIDs, but they cause dramatically more cardiovascular events, making them among the most dangerous medications for seniors with cardiovascular disease. The mechanism involves selective COX-2 inhibition reducing prostacyclin production, which prevents clots and dilates vessels, while leaving thromboxane A2 production intact, which promotes clots and constricts vessels. This creates a profoundly prothrombotic and vasoconstrictive state. Traditional NSAIDs inhibit both COX-1 and COX-2, affecting both prostacyclin and thromboxane, creating more balanced effects. Selective COX-2 inhibition creates imbalance favoring thrombosis and vasoconstriction. The cardiovascular dangers of coxibs became apparent in 2004 when rofecoxib, Vioxx, was withdrawn from the market after studies showed it doubled heart attack and stroke risk. An estimated 88,000 to 140,000 excess heart attacks occurred in the United States during rofecoxib's time on the market. Celecoxib, Celebrex, remains available despite similar cardiovascular concerns because some studies showed lower risk than rofecoxib, though risk still exists compared to placebo or non-selective NSAIDs at equivalent anti-inflammatory doses. Research published in Lancet analyzed all trials of coxibs and traditional NSAIDs, finding that celecoxib increased major vascular events by 37% compared to placebo. High-dose celecoxib, 400 mg daily, increased risk further. The cardiovascular risk with coxibs begins immediately upon starting treatment, with highest risk in the first 30 days. One study found 300% increased heart attack risk in the first month of coxib use compared to non-use, with risk remaining elevated throughout treatment. Populations at highest risk include anyone with prior heart attack or stroke, heart failure, peripheral artery disease, multiple cardiovascular risk factors, and those taking aspirin for cardiovascular protection, COXIBs may interfere with aspirin's effects. What you must do is avoid COX-2 selective NSAIDs if you have any cardiovascular disease or risk factors. The gastrointestinal safety advantage doesn't justify the cardiovascular danger for most patients. If anti-inflammatory medication is necessary, use naproxen, which appears to have the lowest cardiovascular risk among NSAIDs, though risk still exists. Combine with proton pump inhibitor to reduce GI bleeding risk if needed. For arthritis pain, consider acetaminophen first line, despite lack of anti-inflammatory effects. Many patients achieve adequate pain relief without inflammation reduction. Topical NSAIDs like diclofenac gel provide localized anti-inflammatory effects with minimal systemic absorption and cardiovascular risk, making them preferable for localized joint pain. Physical therapy, weight loss if overweight, and strengthening exercises often improve arthritis pain significantly, potentially eliminating medication need. Medication number 2. Stimulant medications for ADHD or weight loss causing tachycardia and hypertension. Stimulant medications including amphetamine salts, Adderall, methylphenidate, Ritalin, Concerta, and lisdexamfetamine, Vyvanse, are increasingly prescribed to adults over 65 for ADHD, cognitive enhancement, or off-label uses. Additionally, stimulant appetite suppressants, including phentermine and phentermine topiramate combinations, are prescribed for weight loss in elderly patients, despite significant cardiovascular risks. These medications work by increasing norepinephrine and dopamine in the brain, improving attention and reducing appetite. But systemic norepinephrine release causes profound cardiovascular effects, including increased heart rate, typically 10 to 20 beats per minute, increased blood pressure, averaging 5 to 10 millimeters of mercury systolic and diastolic, increased myocardial contractility, raising oxygen demand, and vasoconstriction throughout the vascular system. For elderly patients with coronary artery disease, the combination of increased heart rate, increased contractility, and increased blood pressure dramatically raises myocardial oxygen consumption while simultaneously reducing oxygen supply through vasoconstriction. This supply-demand mismatch precipitates myocardial ischemia and infarction. Stimulants also increase arrhythmia risk by enhancing automaticity and reducing refractory periods in cardiac conduction tissue. Atrial fibrillation, ventricular ectopy, and sudden cardiac death have been reported with stimulant use. Research on stimulant cardiovascular safety in elderly adults is limited because most studies excluded patients over 60 with cardiovascular disease. Case reports document numerous myocardial infarctions and sudden deaths in elderly stimulant users. The 2011 FDA review found that stimulant medications increased heart attack and sudden death risk compared to non-use, leading to enhanced warnings on product labels about cardiovascular risks. The American Heart Association recommends cardiovascular assessment, including history, physical examination, and electrocardiogram before starting stimulants in adults. Those with serious structural heart disease, cardiomyopathy, serious arrhythmias, coronary artery disease, or other serious cardiac problems should not receive stimulants. Populations at highest risk include those with coronary artery disease, heart failure, cardiomyopathy, arrhythmias, uncontrolled hypertension, and hyperthyroidism. What you must do is avoid stimulant medications if you have cardiovascular disease. For ADHD in elderly adults, consider non-stimulant alternatives, including atomoxetine, which doesn't cause significant cardiovascular effects at therapeutic doses, or bupropion, which has mild stimulant effects but lower cardiovascular risk. For weight loss, stimulant appetite suppressants should be avoided. Instead, focus on dietary changes, increased physical activity, and behavioral modifications. If medication is necessary, consider GLP-1 agonists like semaglutide or liraglutide, which promote weight loss through different mechanisms without stimulant cardiovascular effects. If stimulants are prescribed despite cardiovascular risks, obtain baseline blood pressure and heart rate, monitor regularly during treatment, start at the lowest dose and increase gradually if needed, and discontinue immediately if chest pain, palpitations, shortness of breath, or syncope occur. Medication number 1, sodium glucose cotransporter 2, SGLT2, inhibitors causing ketoacidosis and volume depletion in vulnerable seniors. SGLT2 inhibitors, including empagliflozin, Jardiance, dapagliflozin, Farxiga, and canagliflozin, Invokana, represent a newer diabetes medication class that also provides cardiovascular and kidney benefits, leading to widespread prescribing in seniors with diabetes, heart failure, or chronic kidney disease. These medications work by blocking glucose reabsorption in the kidney, causing glucose excretion in urine. This lowers blood sugar, promotes weight loss, and reduces blood pressure through osmotic diuresis. While SGLT2 inhibitors reduce heart failure hospitalization and cardiovascular death in appropriate patients, they can trigger life-threatening complications in vulnerable seniors, including euglycemic diabetic ketoacidosis, DKA, a metabolic crisis where blood becomes acidic despite normal blood sugar levels. Traditional DKA occurs with very high blood sugar, but SGLT2 inhibitors cause ketoacidosis at normal or only mildly elevated glucose levels, making diagnosis difficult. Patients present with nausea, vomiting, abdominal pain, and confusion but normal glucometer readings, leading physicians to miss the diagnosis. Triggers for SGLT2 inhibitor-associated DKA include major surgery, severe illness or infection, prolonged fasting or very low carbohydrate diets, and insulin dose reduction. Additionally, SGLT2 inhibitors cause volume depletion from osmotic diuresis, reducing intravascular volume by 10 to 15%. For seniors with marginal cardiac output, this volume loss can precipitate acute hypotension, reduced coronary perfusion, and myocardial infarction. SGLT2 inhibitors also increase urinary tract and genital infections from glucose in urine-feeding bacteria. Severe infections, including Fournier's gangrene, necrotizing infection of the genitals, have been reported. Research shows that SGLT2 inhibitors reduce cardiovascular death and heart failure hospitalization by 20 to 30% in heart failure patients, making them beneficial for most elderly heart failure patients. But certain high-risk subgroups experience more harm than benefit. Populations at highest risk for adverse events include those over 80 years old with frailty, type 1 diabetes or insulin-requiring type 2 diabetes, chronic kidney disease stage 4 or worse, eGFR under 30, recurrent urinary tract infections, and those undergoing major surgery or experiencing severe illness. What you must do before starting SGLT2 inhibitors is undergo education about ketoacidosis symptoms, including nausea, vomiting, abdominal pain, fatigue, and rapid breathing. Seek emergency care immediately if these develop, informing providers you take SGLT2 inhibitors. Stop SGLT2 inhibitors before major surgery or during severe illness, resuming only after recovery and consulting with your physician. Maintain adequate hydration, drinking at least 6 to 8 glasses of water daily to replace fluid losses from osmotic diuresis. Monitor for genital or urinary symptoms, including burning, frequency, unusual discharge, or pain. Report promptly for treatment before serious infections develop. If experiencing recurrent UTIs or genital infections on SGLT2 inhibitors, discuss discontinuation with your physician. The cardiovascular benefits may not justify infection risks in your case. These 8 medications could trigger heart attacks in seniors over 65, decongestants causing acute hypertensive crises, NSAIDs increasing thrombotic risk, testosterone accelerating atherosclerosis, corticosteroids causing fluid retention and metabolic dysfunction, antipsychotics prolonging QT interval, COX-2 inhibitors increasing heart attack risk 300% in first 30 days, stimulants raising heart rate and blood pressure, and SGLT2 inhibitor. The pattern connecting these medications is that benefits may not outweigh cardiovascular risks in elderly patients with pre-existing heart disease. Careful risk-benefit assessment, use of safer alternatives when available, lowest effective doses, and vigilant monitoring can reduce medication-induced cardiovascular events. Which medication surprised you most? Comment below sharing your thoughts. Share this video with seniors taking multiple medications. Subscribe for more medication safety content. Thank you for watching this video about medications that could trigger heart attacks in seniors over 65. Review your medications with your physician to minimize cardiovascular risks.